Clomid for men, Clomid for TRT, Clomid for low testosterone, Clomid for men's fertility. Those are all YouTube search terms that are very popular. So can you cover them all in one short video? Okay, Gil, welcome back to our channel.
Thank you, Stephen. Happy to be here as always.
Clomid for men, Clomid for TRT, Clomid for low testosterone, Clomid for men's fertility. Those are all YouTube search terms that are very popular. So can you cover them all in one short video?
Absolutely. Clomid is the nickname for medication called clomiphene citrate. It's an oral medication. It is often dosed in 50 milligrams, sometimes 25, and then if it's broken into 4, 12 and a half. It's designed as a fertility drug, and it's indicated for fertility specifically. And it's a class of medications known as a SERM, S-E-R-M, which stands for Selective Estrogen Receptor Modulator. What this class of medications essentially does is it does not directly act on a hormone by changing directly. It does indirectly, and I'll get to that in a minute. It doesn't directly change hormone levels in the body. It simply blocks the receptor sites or the active sites of the cells that are going to receive that hormone signal and then effectively have a chemical reaction to it. So by occupying a receptor site without actually activating it, what you're essentially doing is you're mimicking a low state of serum for that hormone, because our endocrine system, as we know, has two types of mechanisms: positive feedback, which is less common, and negative feedback. Example of a positive feedback would be something like oxytocin, which works on contraction of mammary gland tissue for breastfeeding, as well as uterus contraction. So this is something that is common for women when they give birth. But the negative feedback system is the one that we're more familiar with for the general tropic hormones that stimulate production in glands within the endocrine system, and that would be our sex hormones, various different steroids, our metabolic function through the thyroid and so forth, adrenal cortex and whatnot. So the negative feedback is very simple. When one signal goes up, the production of the other hormone will go up, and when that hormone is sufficient, the signaling hormones will come down. So it's kind of like a seesaw effect. Our pituitary gland, which is the master gland of the endocrine system, is very heavily regulated by negative feedback mechanisms, specifically the anterior pituitary, or adenohypophysis, as it's also known. And this gland is very sensitive to how the receptors in that gland are being agonized by various compounds. So estrogen, as it elevates in our blood from the process of aromatization, enters the blood serum circulation, hits the pituitary gland, as well as the hypothalamus, but I won't get into that one. Let's focus on the pituitary. It essentially tells our signal in our brain, we have enough, you can go ahead and turn that faucet off now. And that's when your luteinizing hormone essentially would be diminished. And follicle stimulating hormone follows along as well. When you're taking clomiphene, or a class of a SERM type medication, what you're doing is you're occupying the estrogen receptor systemically, but some of them have a bigger binding affinity to some parts of the body than others. And Clomid is exceptionally strong in the brain. So it does block a lot of the estrogen signaling in the brain. And it tells your body you're in a constant state of estrogen deficiency, essentially, or a low state of estrogen. As a result, your testicles will kick on, your pituitary will pump up more LH, and the LH will stimulate more testosterone production. This is commonly why we see men who suffer from secondary hypogonadism, which is not specifically testicular hypofunction induced by Leydig cell desensitization, but more so testicular hypofunction secondary to the pituitary failing to put out gonadotropin signals. This will spike gonadotropin signals. So on the labs, you're going to see that all of a sudden the testosterone levels are shooting way up, and the guy doesn't report to feel any better. Initially, they may, but then very quickly that subsides. And then as time goes by, over the course of 3 to 6 months, assuming they're using a Clomid monotherapy approach, you're going to notice that the mood swings start to come in, depression sets in, libido begins to diminish, and all the metabolic benefits of estradiol begin to diminish, weight gain begins to set in, etc. And this is directly a result of, while estrogen serum and presumably paracrine levels are sufficient, they're not able to act on the target tissues. So it's almost like saying you got all this money in the bank, but you can't use it. You're still poor, right? You're going to suffer the poverty symptoms. If I put $1 million in your bank account and I don't give you access to it for 10 years, you're still living in poverty. And this is essentially what a serum does. So it has its place in a short-term kickstart or a short-term fertility spurt. It does not have a valid place in a replacement therapy for TRT because it is often short-lived. It causes more damage than it does good. And as soon as you take guys off, over 90% of the patients who have done fairly well on paper are going to crash back down. So it is a non-sustainable approach, and I dislike it. I do understand why the medical community uses it, and it's primarily more for litigation mitigation, okay? Specifically in younger patients, they want to say, well, we've tried all of the non-invasive methods first, they failed, and now we're going to go ahead and put the guy on TRT, but at least they can chart and document that they've made every viable attempt. And they know damn well it's going to fail, but again, they do this more to cover their butts and be able to say that we didn't just resort to TRT out of the gate. And I dislike that part of medicine. Again, this comes down to doing things that you know are incorrect for the sake of satisfying the legal system. And that's up for discussion. But in short, Clomid has a lot of negative side effects, including depression, potential sexual dysfunctions, and including some vision loss, because remember, you're also blocking some of the estrogen receptors related to the optic part of the eye, which in the back of the eye, you have some estradiol that's responsible for some of your vision. And when you block that, you're also going to experience potential floaters, and over time, the longer you stay on it, it's also dose dependent, you may develop hyperopia. So not something that is recommended for patients, especially long-term, in lieu of TRT.
Mm-hmm. Where does the use of this product come from in the medical world? Is it from the bodybuilding because it was used as PCT?
Yeah, so it's very common in the bodybuilding world to do what's known as a cycle. And a cycle is essentially a short-lived run of anabolic steroids ranging from 10, 12, 16, I've seen 20, 24 weeks, et cetera. But however long a cycle is, it usually uses some compounds that are suppressive or inhibit or shut down the natural production of the hypothalamic pituitary testicular axis. So in order to kickstart that production and avoid for a younger bodybuilder to stay on a low dose testosterone indefinitely, what they do is they do what's known as a post-cycle therapy or a kickstart of their HPTA. And the way they do this is they use a gonadotropin mimicker, like human chorionic gonadotropin, for a period of time. This kickstarts the testicular function, and then that's followed up with a SERM, either tamoxifen, aka Nolvadex, or Clomid, or any class of SERMs that essentially is going to help kickstart the pituitary gland. So again, it has its place in a kickstart protocol. It does not have its place as a replacement therapy, if you will, for the reasons I mentioned earlier. So I think that the bodybuilding community certainly put that into the mix long ago. I think going back to the 70s is when it was used most commonly, and then it just kind of lingered, and it's still being used today in bodybuilding. However, a lot more guys are kind of staying on T all year round now at moderate doses because they realize that turning the switch on and off continuously will eventually fry your pituitary function, and you're not going to recover. Why the medical community chooses to use this, again, I can understand if it's a very young person, if there's a legitimate lifestyle, perhaps, reason for why their pituitary function is diminished. We can certainly try a short-term kickstart. Again, I'm not a big fan of Clomid for the side effects. However, even if the side effect profile is short-lived, a lot of people are really overdoing it, and they're doing it in the wrong patient, where there's just no chance of recovery.
Okay, very clear. Thanks, Gil.